Very happy to be here, to have the opportunity to speak about my research and the work of my team on AI in disease prevention. I'm a professor in public health and aging, so I'm looking at this from the people affected by data science and using data science to achieve their goals. And I have a bit of a fluent definition of disease prevention. So take type 2 diabetes, for example. It can be considered as an outcome that we want to prevent. But type 2 diabetes is, in my research on healthy and unhealthy aging, really a risk factor that needs preventing. So while some applications I'm speaking about today can be considered prevention, they can also be considered disease management already. So why prevention? My domain is cognitive aging and dementia, and as you know, there's a high dementia, for those who don't know it, is the range of conditions characterized by memory impairment and functional limitations. Age is the strongest risk factor, and there's really not many drug-modifying therapies yet available. It comes with a high cost, economically, societally, and that being said, so when it occurs, it's not treatable anymore, but it makes a lot of sense to think about cognitive aging and dementia and also many other aging-associated diseases from a preventive perspective. For example, the Lancet Commission on Dementia recently estimated that modifiable risk factors make up about 40% of all dementia cases. So 40% of dementia cases could be prevented if these were addressed. How do these risk factors look like? Here is an infographic by the Lancet Commission on Dementia. You see here the different risk factors across the life course, and I can read a few. For example, hypertension is very important to prevent excessive alcohol consumption, depression, social isolation. So if we target these risk factors, we can make a lot, we can gain a lot in terms of preventing cases of dementia or delaying them up to very advanced age. There's also several guidelines now available that translate this scientific knowledge for the users, for healthcare professionals. So this is the evidence we are speaking about here today. I put on a few of these risk factors for dementia, but it really also applies for a risk for other aging-associated diseases. So targeting these will really help you lead a more healthy life and age more healthily. How could we do this with AI? A few use cases you surely can think of right away. I think the three dimensions, the three purposes of AI in prevention are first, detection of risk factors. This means that we can use wearables, devices, more data collection to detect risk factors much earlier, at earlier stages, and have thus a higher chance of reducing the risk of these aging-associated diseases. We can also, for the users, educate, counsel, and provide personalized advice. And this is really also the focus of my talk here today. So I'm not talking about generative AI in terms of text-to-image or text-to-music. It's really text generation, conversational agents, and large language models in general. So this is really helpful to feedback health data to the user, and also healthcare professionals can be assisted by AI in their decision-making, in their diagnostic process, and in the care pathway. And we're not saying provide expertise to the experts. Of course, there's a lot of expertise in the doctors, for example, in the nurses already, but AI can assist them in providing knowledge on special cases, rare cases, providing knowledge on user groups that these doctors or the nurses normally don't see, and we will speak about that later. So a bit more detail on these different applications. Detection of risk factors can be, if done well, be really helpful. And I looked into the numbers, for example, of how Fitbit, sorry, I'm saying the name, but of course there are many variables that you can imagine, and they have different detection of risk factors, but for atrial fibrillation, for example, the numbers are quite nice. So if your watch tells you may have experienced atrial fibrillation during your sleep, then it's really good to go to the doctor, because a certain percentage of users will really have this condition. And it's important to detect atrial fibrillation very early, because then you can modify the risk, and you can work towards preventing these major cardiac events that are associated with these risk factors. We can provide personalized advice. We can adapt to the idiosyncrasies of users, but we can also adapt to cultural differences, sex, gender differences. Men and women react very differently when it comes to lifestyle advice, for example, for dementia prevention, and we can all factor this in. And many variables feed back a lot of health data, and I would say not many users need this level of detail. They can make sense of the numbers themselves. So we can give a narrative feedback, a conversation, a short paragraph on the health status of a person, which then can also have a disclaimer, have some advice, some recommendations in some motivational aspects. So that's really interesting to use these conversational bots in that field now. And for the decision-making support for healthcare professionals is maybe less relevant in a high knowledge context, high knowledge healthcare system like Luxembourg and neighboring countries. But I recently listened to a doctor practicing in South Africa. He spoke at the same panel on healthcare and AI assistance as me. And what he said was that at the moment they don't have qualified healthcare staff in South Africa, in the region he's working. They have a shortage of staff, so every AI support that could be delivered, even if imperfect, could make a big difference for them. Okay, we recently analyzed views on AI in healthcare issued by interinstitutional, intergovernmental organizations such as OECD and WHO. And what we saw here, there's this optimism of the Silicon Valley that AI will independently kind of decide our lives and decide on how things will be done in the future. So this really kind of over-optimism. And then the guidelines really try to push back here. They have a strong regulatory ethical perspective, and what the ethicists, scientists, the regulators are really very critical, and maybe just too critical, but there needs to be a calming down maybe of both sides. This is what we found. I spoke about the strong healthcare professionals' wishes to enrich decision-making. Some user groups may even be indifferent about the use of AI. For example, patients surveyed in Switzerland, this was done at the University of Basel, they trusted the doctors in a way that they said, okay, the doctor knows best if they want to use AI or not for decision making. I just do what the doctor tells me. And so now the decision to use AI or not is with the doctor in their views. Okay, so some benefits of large language models in disease prevention. And just to say, at the moment, there's not much spending on preventative services. So most of the healthcare spending is really going to treatment. So there's really a lot that can be gained by looking at conversational agents and other AI models that collect and process data. Process the data collected more systematically. So we can think about increased efficiency and accuracy of care simply because errors will be avoided. A checklist can be run through. Administration could be optimized so that the doctors really spend less time on administrative tasks. In a recent study where mental health care services users were asked if they preferred a human therapist or an AI psychotherapist, actually 55% preferred the AI psychotherapist, particularly those who were not well available during working times or those who had embarrassing or shameful experiences to share. So they felt better speaking to the bot. What has been shown, I'm a scientist, so I'm citing the scientific evidence for why it works. Psychoeducation for low literacy users works. High literacy users may not really need it. And disease management, for example, of type 2 diabetes has also been shown to work through a conversational agent. But then developing these digital tools, the health tools, the large language models that can assist the users and the healthcare professionals, we need to think a bit more closely on what we are feeding into the model. I'm just citing from this great project, the Search Ahead in Germany develops AI assistants to surgeons who deal with geriatric patients. And this is interesting because surgeons normally don't see geriatric patients. So they know less about this user group. The researchers collected 95 clinical practice guidelines. They extracted 852 recommendations out of these guidelines. And what they saw is that over half of the recommendations had very low evidence or low evidence to support these recommendations. So we need to have a discussion here, what we are feeding the AI model with. Is this acceptable as input for our AI models? We are speaking a lot about the human in the loop. It's fine to first have a testing of AI recommendations, but just to say the humans are humans, and we will have users more readily believe AI recommendations and take them to be true if they confirm our own beliefs and hypotheses. So we need to be very critical in the testing phase of these recommendations. I'm working on social determinants of health, so how the conditions in which we live, work, and grow old in are influencing our health. So I see a lot on the problems if there are systematic inequalities in the data that we use to build our models. For example, in the US, we know that healthcare is very different for whites, blacks, and Hispanics. This lower quality that black patients will receive is fed into the algorithm as being true, right? So the AI model will also then give recommendations that will lead to lower quality care pathways for blacks, and this is not acceptable. I recently looked into AI auditing because that's really an interesting thing to really have a post-deployment a session where you look into AI, the performance of the model and if it meets your standards. And here we can do a systematic assessment of the different stakeholders and which stakeholders would be hurt by which errors of the AI model. Okay, so why health psychology? We all know that smoking is bad, that physical inactivity is bad, that we should maybe reduce our caloric intake, but we have trouble changing our health behavior, and here really health psychology has a lot of knowledge to offer to bridge this knowledge implementation gap. So we really need to think carefully about preventing hallucinations of the models. So we need to be very conservative. In a recent study looking at ChatGPT 3.5, migraine prevention advice was made up to 66%. So 2/3 of the advice totally hallucinated. So this is not acceptable. So we need to have validated scientific knowledge grounding the large language model. We cannot go into the details, but if you want to look at how we in a recent project for brain health at the workplace implemented health psychology into brain health advice, have a look at our platform, getbrainhealthy.org. And here we have collected a lot of actions on employees, and also for managers. We have processed over 200 scientific studies, and we are now rolling this out for employers and employees to benefit from brain health advice. Okay, so that's it. Thank you very much, and I'm looking forward to the discussions in the panel.